I'd like to request Chairpersons Dr. Pushpa Sarkar, Director AHS Dayanand Sagar University, and Dr. Susanta Kumar, Professor, Head Noble Medical College and Teaching Hospital, to kindly come on to the stage. All right. I'd like to request Dr. Gitanjali to take over this session. Over to you, ma'am.
Sir, if you don't mind, I have a flight to catch, so thank you. I'll just start presenting. Can I start? Respected Chairperson, whoever's here to listen to my talk, thank you very much for giving me this opportunity, to Dr. Shivamurthy and the organizers of this conference. It's a great feeling to be here. All the delegates who are here, I'm going to talk to you about leadership in academia, what works and what doesn't, to share a little bit about my experiences in the past few years. So people often think that leadership is about authority, and no one prepares you for the truth. There is nothing about authority or being in control which is what leadership is about. It is totally something else. So I have been in all these institutions. You can see JIPMER on this side. Then you see the institution I'm there now, Geetam University, and then there is AIIMS Kalyani, AIIMS Guwahati, where I was director in additional role, as well as AIIMS Bhubaneswar, which I was director for the last, for about 5 years and 3 months. So academic leadership in India is a very, very difficult ball game, and it's a huge thing where you have to balance yourself all the time. So don't think otherwise, but it's not as if it's something which is very stable or something like that. We have temples of learning on one side, and on the other side, those same places will be deeply bureaucratic. Unless you move a file, you can't do anything. You will have students who are the brightest minds in the country, and the faculty will be using some same PowerPoint which they used for 20 years. They have never bothered to brush up and things like that. There are plenty of resource constraints of many of the institutions, as well as apathy, inertia, and hierarchy, and so on. So it's a very mixed bag you inherit when you take over as a director or you take over academic leadership. Now, one of the things is we are deeply, we look to our tradition. So we want to be as traditional as possible. At the same time, we want to bring in new changes. So there is this huge thing about, should I be very traditional or should I change, kind of a thing. And this is something which you learn to cope with as you, navigate your way through leadership. So you need to respect tradition and the institutional culture. Hopefully it's a good culture. And you need to have the courage to challenge when something is not working. This is the problem, because people don't expect you to challenge. Especially if you're a woman, forget it. They expect women to be really meek and not question anything which has been going on. We also have what is called a huge power distance. So the director, the vice chancellor, the chancellor, they're all somewhere up in the sky, and the rest of the mortals won't even look down. And this is a known fact. India is one of the countries where we have a huge power distance. You will see medical superintendents won't even make eye contact with a pharmacist. They don't even consider pharmacists part of their team. So you have this kind of power distance, and unless you learn to address these things at the beginning, you have a huge problem. Most of leadership begins with a cycle of unglamorous work. Don't think that the work is extremely glamorous where you're going and sitting in these kind of stages and getting prizes and so on. Whole amount of unglamorous work. You need to ethically model. Unless you ethically model the way you want your faculty to behave, it's not going to work. So you need to set the tone right at the top. And then there has to be accountability. normally what happens is when something goes wrong, leadership tends to push it to the people at the bottom and say, you are the problem. No one takes accountability. That can't happen. It always, the buck stops at the head, at the table of the person who is leading the institution. So you need to have hard conversations. Sometimes you have people who are plain bad or nasty, or they're not doing things the way you want to. You need to have such hard conversations and tell them, this is not how I want things to be. But you should do it in a way in which you don't destroy morale. So you can't say, no, you know, shut your mouth and stay there. You can't do that, because next time you want some help from that same person, that person is not going to help you. So you need to have hard conversations without destroying morale. And then, of course, there will be friction. It's not going to be a cakewalk. There will be people who like you, there will be people who don't like you, and therefore you need to navigate institutional pushback. Because you want to do something, especially if you want to improve standards, there will be people pushing back on quality. So you'll need to understand that. You need to make sure that infrastructure and systems are in place, because once you start putting those things in place, it is a visible signal that you are invested as a leader. So put those things in place, and then of course you need to bring in a culture shift to suit your way of thinking. So this is the major thing, and if you can bring that, then your whole cycle becomes much more enjoyable. So the whole thing is this transforming academic culture is a relentless, iterative loop. It's not just that, you get up and everything falls in place. It's not going to happen like that at all. So the eventual outcome will always feed into step one, which will be the ethical modeling. So it's a tightrope, and we need to know how to model this. So let me talk about what works. I mean, there are a lot of things which work, but I'm just going to give you just a few of the things which worked for me, right? So the first thing is, leadership is not doing everything yourself. You'd love to do everything yourself, but it's not that. It is ultimately delegating it to the right person. So the key word is the right person. You can delegate, but if you delegate things to the wrong person, again, you're not doing it the right way. I'll give you an example of how we set up the Central Sterile Supplies Department at AIIMS Bhubaneswar. That gentleman in that photo is Professor Ashok Jena. And Professor Ashok Jena was head of dental services. He's a dentist and orthodontist. And I gave it to him because he was keen to take it, and then I forgot about it. And today, if there is something I can be very proud of, it is the CSSD at AIIMS Bhubaneswar. It's a fantastic CSSD. If any of you find time, please go and visit that place, because it's really, really very good. And I didn't do anything. I just gave it to somebody. Similarly, we have the story of the Kaya Kalp Award. Kaya Kalp Award is given by the government for hospitals which maintain some cleanliness, and they have so many things which we have to take care. Basically, it is all cleanliness, and it has to do with infection control and so on. So the first time I went for Kaya Kalp Award ceremony, we didn't even get a consolation prize. And I was feeling so upset, because some of the other AIIMS got. So I told the person next to me, next year we are getting a prize. And we slowly started working up from that. So the next year we won the second prize. The third year also we won the second prize. And the fourth year we won the first prize of 2 crores. What happened in between is we put in place a lot of systemic changes which we brought into infection control, into cleanliness, and so on. The entire thing was handed over to the Department of Hospital Administration, which took this thing and ran with it. So delegate to the right person. That's the story. Leadership is not about a solo performance. Though, leaders get to have that kind of a thing. Who's a director of so-and-so and all that. It's absolutely not a solo performance. It is when the director or the person at the top has the capacity to release and engage human potential so that they can bring out the best as a performance. That is what leadership is. And time again, you get to prove that. And I'll give you an example. When I joined AIIMS Bhubaneswar in 2016, October, research was not a priority. And last month, I went to AIIMS Bhubaneswar for the Department of Medical Gastroenterology was celebrating 10 years of having established itself. And when I went there, they gave me this, this brochure. And in that brochure, if you see the publications, please look at the publications in 2016. They have 3. So when I joined, they had 3 publications in a year. And then in 2018, they had 6. By the time I left AIIMS Bhubaneswar in 2021 December, can you see they had 41 publications. So from 3 publications, they went up to 41. Of course, there were other things. There were new people joined as faculty members. They started the DM program and so on. But if you look at this metric, you can see how we did it. It's not just that all of a sudden, they started doing good research. We had to put in place a lot of things. We had to put in place a research cell. We had to literally teach people how to write scientific manuscripts, how to do research, how to write a research question, what is PICO, and so on. So all that things happened, and so over a period of 5 years, you got to see a good amount of research. So this is a center of excellence for clinical microbiome research, which we set up. We wanted 66 crores. And the secretary, she said, absolutely no. We will not fund research. If you want research, you please go and ask ICMR or DST, DBT. We don't fund research. Then I told her, ma'am, this is a new institution. We don't have a track record. How do you expect our faculty to do research if we do not have the equipment? And so I was fighting so much that she got sick. And then she gave us 22 crores to start this Center for Microbiome Research, which Professor Vinod Paul opened. And that now they have any number of grants. It all started with Dr. Balamurugan. You can see that guy with a beard, and pepper and black beard at the back. He was a JIPMA student. Probably Melvin knows him. Melvin, you know Balamurugan? Melvin is not here, okay. So right now they have ICMR grants. They have huge crores of ICMR grants. They have gates grant challenges they won. 3 people have completed the PhD, 2 people have submitted the thing, and another, I think 5 are working on their PhD. Why I'm saying it is, it can happen not because I did anything. The research infrastructure was put in place. So what I want to say is, I only created the conditions. Faculty did the job. So I can't actually take any praise for this, because that is what a leader is supposed to do. You're supposed to create conditions so that people will be in a position to do their best. So leadership is not a sprint. You can't get up one day and think it will be over. It's a kind of a marathon. You keep running it and improving and improving and improving. So the real work of leadership is, it's very unglamorous, like daily enforcing accountability, making sure that operational systems are put in place, or demanding rigorous professional conduct. So in other industries, if things go bad, that means, it's always money. But in medicine, if things go bad, 2 things. One is patients get affected, and number 2, students get affected. So you really can't take a risk with leadership. You need to build things which will survive in spite of you. So even after you leave, those things should be in place. That is what you should do as a leader. So very quickly, what doesn't work? One is, there is no myth, this myth of hero leader. Somebody is a great leader and they'll bring in all change. This is all, I don't believe in that at all, because your job as a leader is only to build capacity in others, not to demonstrate your own capacity. That is not there. The second thing is when you confuse busyness with leadership. Many leaders like to say, we are very busy. We don't have time for anything. I don't have time to attend a sports meet. I don't have time to attend some functions. And if you have to meet them, they'll give you an appointment after 1 month or 2 months. By the time you would have forgotten also what you want to do, what you want to say to them, or that would have managed or got solved by themselves. So busyness is not leadership. And you need to come out and meet with people, especially communicating only through circulars is a bad thing. And you need to engage with students because it is an academic institution. You have to talk to students to find out what are their pain points. The other thing which does not work is when you start avoiding difficult conversations. See, as a leader, there will always be problems. But if you don't want to talk to somebody, oh, I don't want to talk to that person, no, you have to have difficult conversations. Get it out of the way. That is an important aspect of leadership. And then, of course, absence of moral credibility. Today, the pro-chancellor also said the same thing. If you lack morality, nothing else matters. So ethical inconsistency, having double standards, academic dishonesty, some leaders, when they are HOD, they will say, every paper I must be an author. This kind of academic dishonesty, giving gift authorship to the HOD's spouse and things like that, this has to stop, okay? And therefore, when you start exploiting junior faculty for your own things, so don't think leadership means I'm only talking about directors or, big posts. Leadership can be at much smaller level also. You might be a leader of a unit. You might be a leader of a department. So you need to ensure that you get all these things and try to see whether you can be a better leader. So what kind of leader will you be? So I feel it has three dimensions. The first is, of course, character, right? Are you honest? Will you do what you say you will do? Will you take responsibility when things go wrong? These are the three major things which puts your character as a good leader. So that is the foundation. So don't take a risk with this. You need to prove yourself. The second one is the competence. You need to be a competent person. So you need to be scientifically, you need to be competent. You need to be academically and research oriented. You need to know your stuff. If you don't know your stuff, no one will take you seriously. I can guarantee that, okay? So you also need to develop your communication skills, not just speaking skills, but also listening. All the time you need to listen to people before you start talking. And then you make decisions with uncertainty. Building systems, because that's the competent part, where things after you walk away will still work, and then developing people. So these are the 5 dimensions of competence. And the first 2 are really very, very important, okay? So develop these skills if you want to be a good leader. The third one is courage. That is, you need to disagree with people when you know they are wrong. The courage to admit a mistake publicly, and then to protect a junior colleague who is treated unfairly, and the courage to change something that has always been done this way. These are all examples of courage in leadership. And unless you have the courage to stand up and say, this is how I will do, you will not be a good leader. So you might have character and competence, but if you don't have courage, you'll be a manager who never leads. You might have character and courage, but no competence, you'll be totally ineffective. So you need to develop competence. And then you might have competence and courage, but lack character. That's very, very dangerous to have in a leader. So these are the 3 dimensions. So most of the effective medical leaders, they align formal authority with moral authority and expert power. When all these 3 comes, then influence becomes sustainable and it is non-coercive. So authority gives you the right to decide, power determines whether others will follow. So I am finishing with a small African proverb about what I learned on the way. So they say, this is an African proverb which says, when a fish rots, the head stinks first, okay? So failure always begins at the top. Leaders guide actions, they guide rules, they guide direction. And so when leaders fail, systems fail. Accountability always starts with leaders. So this is really very important in leadership. Thank you very much for a very patient listening. Thank you.
Thank you very much, madam. Nice presentation. Now it is open for your questions. Any question? Yes. Yes, please.
I thought some youngsters would raise their arms. They didn't do it. I'm doing their job. We have become Buddhas. They are the ones who are going to become leaders, or at least aspiring to be leaders. But okay, let's come back to one question I have it. You told, okay, it's not a solo sprint. It is finding the right person to delegate a job. Find the right person, leave it and forget. Right? Now, I have a problem, which I myself have experienced it. You have 10 people, but suddenly you find that none of them have the potential. Okay, one doesn't know anything. Another one, what you call, Kamchor or escapist, whatever you call. You don't have anybody whom you can assign the work. Then what is your next step? What are you going to do?
Sir, so you can't assign and forget about it. That was a bit of an exaggeration. Which
I don't find in the first place, I don't find the right person
Yeah.
to delegate the job.
Yeah, so if you don't find the right person, the only thing is for you to write down the steps, how you want something to be done, and then guide a person whom you feel who has the potential to do it. Because as a leader, you can't be doing everything. You'll burn out. Or you give yourself priority. So one is you guide a person. That person may not know how to do it. But at least if that person has a good heart, you'll be able to say, okay, do this, then you come back. Do this, then you come back. So at least the physical work is being done by somebody. You have to find the right balance. Always things won't work out in the way you want.
Thank you so much.
Thank you, sir.
Yes. Next question.
Good afternoon, everyone. My question is, should a leader always be, diplomatic? Or is it necessary to have that kind of...
Ma'am, the thing is they say that sometimes if you want to be honest, you need not be brutally honest because people enjoy the brutality more than the honesty. If you were always diplomatic, things won't work. So at times you have to call out people. As I said, you need to have difficult conversations. So you need not always be diplomatic, but at the same time, you don't have to be so brutally honest that, people will stop responding to you. So you need to strike a good balance, but you don't need to be always diplomatic. I really don't believe in that.
Thank you.
Dr. Prince?
Yes. Next question.
Good afternoon,
Yes.
ma'am.
Just one moment, ma'am. She's been waiting. After that, yeah. Yes, Dr. Prince. Go ahead, ma'am.
They have put out various departments and they've called them as toxic. What is your opinion about this? There are many departments that are called toxic, if you see in
Yeah,
the...
pharmacology is one of them. I know. Whenever I was there, they used to call me very toxic. I agree.
In the Facebook, they have a ongoing ranking of this department here and that department from that institute. Aren't you all aware? Yeah, there are
You're
such-
right, ma'am. So one of the things, for example, when such things happen, it's not very uncommon, especially nowadays, because students feel slightest thing. If you are a little strict or there is a test in which the paper is a little hard, difficult, they will. My thing is, when such things happen, have an open conversation. Call them. You won't be able to call all 150 or 200 students of them. Tell them I'm willing to sit with 20. You select whom the 20 are. Call them and ask them, what do you mean by having a toxic thing? Give me specific examples. And you will find many times they don't have specific examples. It will be some student coming about 20 minutes late and the teacher saying, I'm sorry, I can't let you in, becomes an example of toxic. So you need, I am very clear on that. When it comes to discipline, we call the shots. You have to tell them, I will start my class at 2 minutes past 8. Anyone coming after that will not be allowed. That's all. I'm telling you, this is the last time I'm telling you. So these kind of things are, it happens, ma'am. But I would say this is how I deal with it. Call them openly and ask them and say, tell me what you mean by toxic behavior. What are the things which you have observed? Because we can do something about those specific instances. We can react to those instances. That's the only way we can, deal with this. Yeah. Yes, somebody wanted?
Yes. Dr. Gitanjali, for the last 10 years, I think you are playing the role of a leader. How do you assess your performance? You may answer, may not answer. It's a very personal question.
My performance, I would say, was at AIIMS Bhubaneswar. I think we did a lot, but we desperately had a bad luck with the 2 years of COVID and 6 months with that cyclone Fani, because it destroyed a lot of infrastructure. We didn't have the money to buy things and all that. And COVID really, struck us hard, like it did for everybody else. So if you take the 3.5 years which I had without these things, I think AIIMS Bhubaneswar was a good run. Geetam is a very different thing, but I think Geetam also is fairly okay. I know people don't like me. I mean, that's a different thing, but that's a different aspect of leadership, because if you are strict, and as I said, I have to model ethical behavior. So people say that I'm one of the only senior people who come at 9 o'clock. I reach my office at 5 to 9 and I don't leave before 4 o'clock at all. So these are new things which happen in some institutions. So yeah, so it's a thing, but yeah, I'm also getting tired now.
Okay.
Yes, last question, because I have to take a flight. Yeah.
Yes, ma'am. So you said the 3 C's: courage, competence, and character. So when it comes to courage, so in a case where I have to self-preserve, say I'm in a pharmaceutical company and I have a team to manage, and in this situation, if one of the people under me commits a mistake and or is being blamed for something he did not do, and my superior, be it the CEO or someone else who's in charge of me, is like, how do I stand up for my subordinate who is not wrong without offending the CEO? And the CEO is known to have a very short temper. So how do we show courage in this situation without us losing our job or ruining our relationship with the superior, while also standing up for the one below us?
So let me tell you one thing. Many of the leaders don't like to be openly spoken to in front of other people. So if you're sitting in a meeting, you can't tell your CEO, I'm sorry, sir, I mean, he was not to blame, that kind of explaining. He will not take it, okay? You meet your CEO after 1 or 2 days, and you go and explain to him, he will take it. Because that time, the CEO is in a comfort zone. Nobody is looking at him, it's only one-on-one. So at that time, he will take it. But if you try to defend your colleague in front of other people, they won't, mostly they don't.
Thank you, ma'am.
That too, being a woman, no, you need to know.
Yeah. Ma'am, that was a nice brief presentation of yours. And when you said people don't like you, and people respect you. So that needs to be understood, because like and respect, because students are different, faculty are different too. So there's nothing like, madam, because most leaders are not popular. They don't get visuals, claps and things like that. But they do get respect. That I know by my own experience. But I don't care whether people like, not people pleaser, but you stick to your ethics and honesty, it does work. And in academics particularly, you don't work with authority here. There's no fear, because corporate is different. Administration is different, whereas here you have intellectuals, you have people, dealing with medical people. And so you can't rule. I mean, the authority is that with integrity and trust, things are managed with that.
Thank you, ma'am.
Yeah.
Ma'am, if you don't mind, can I take your leave?
Yeah.
If you don't mind, can I take your leave? Thank you. Thank you so much. I already I don't know. Already you gave me.
Thank you for that insightful and yet very thought-provoking presentation, ma'am. We truly appreciate your presence. I'd now like to request the chairpersons to felicitate Dr. Gitanjali, ma'am. Thank you so much, ma'am. I'd now like to request the organizing committee to felicitate the chairperson as a token of appreciation and gratitude.
Good afternoon, all. I would like to welcome Dr. Pushpa Sarkar, ma'am, who is the Dean, School of Health Science, Dayanand Sagar University. She is a visionary academic leader known for remarkable contributions to curriculum innovation, research administration, and institutional development. She was the former Director of Curriculum Development and Research at RGHS and Dean and Director of Mandya Institute of Medical Science, widely respected for transformative leadership and dedication to healthcare education. Thank you, ma'am. Now I would like to welcome Professor Susanta Bordoloi. Sir is retired professor of pharmacology with experience as professor and head of department in various Assam government medical colleges since 2007. Served as medical superintendent in AMC and also worked as an MC inspector. After retirement, he has worked as professor and head of department at MGM Medical College, Kishanganj, Bihar. Retired on 31st December 2023 as professor and HOD at the age of 70 years. Currently working as professor and head of department at Nobel Medical College, Birat Nagar, Nepal. Thank you, sir.
Thank you. Thank you, everyone. To chair the next segment, I'd like to invite our respected chairpersons, Dr. Farhana Rahman, Professor, Shri Balaji Medical College, Hospital, Chennai, Dr. Preeti Praveen, Professor and Head Bharati Vidyapeeth Deemed University Medical College, Pune, to kindly come on to the stage. Thank you, ma'am. Now I'd like to request the organizing committee to kindly introduce the chairpersons.
So I'm here to introduce Dr. Farhana Rahman. Dr. Farhana Rahman is a professor at Shri Balaji Medical College and Hospital, Chennai. She is also a clinical pharmacologist, academician, and researcher with interest in clinical, preclinical trials and molecular research. Here is Dr. Farhana Rahman.
Good afternoon, all. I welcome Dr. Preeti Dhande, ma'am. She is the professor and head of pharmacology, clinical pharmacy, and pharmacovigilance, Bharati Vidyapeeth Medical College Hospital and Research Center, Pune. NABH assessor for entry-level certification of hospitals. She is the author of 66 publications and 19 registered copyrights. She is a quiz master and invited speaker at various academic events. Hearty welcome.
Thank you. I would now like to request the chairperson, Dr. Farhana Rahman, ma'am, to kindly take over the proceedings and introduce Dr. Kavita R., Professor and Head of Pharmacology, Sri Ramachandra Medical College, Chennai, who will be speaking on pharmacognomics in clinical practice and conduct this session. Over to you, ma'am.
Good afternoon, everybody. I welcome Dr. Kavita ma'am to start the topic, pharmacogenomics in clinical practice. Ma'am, you can start.
Thank you very much. Good afternoon, everyone. At the outset, I would like to thank Dr. Shivamurthy sir. So he is organizing chairperson and professor and head of that CDSEMR. And I'm glad to be a part of this prestigious conference, MPSCON2026. So move on to my topic today. So I would like to present a case scenario. A 24-year-old engineering student brought to the emergency department with high-grade fever, extensive skin peeling, painful oral ulcers, and he was prescribed carbamazepine 3 weeks earlier. And you could see the reactions here. So it has happened after 14 days. So can I get the answer? What could be the reactions following this administration of carbamazepine? So it could be a Stevens-Johnson syndrome, progressing to toxic epidermal necrolysis. So do you think this is an area? So everyone can agree. So is it preventable? So what could be the cause for these reactions? So mainly because of the change in the genetic variants. So that has happened in the HLA-B, star allele 1502. So here what will happen? So when the patients or the people who carries this genetic variant, so when you administer the carbamazepine or phenytoin anti-epileptic drugs, so can interact with this cell surface cell antigens and interacts with the peptides that change the shape of the peptide and can stimulate the immunological reactions, can end up with Stevens-Johnson syndrome. And this is a genetically mediated reactions, and also it's it can be avoidable because so here still now we have pharmacogenomics or genetics is in role, and you can see that we can order the testing for this gene. So when you aware about the high risk populations, so FDA recommend to undergo pharmacogenetic screening when you prescribe this drug carbamazepine. So do you think that these reactions can happen to everyone? No. So everyone will agree that there is an inter-individual variations exist when you administer a drug. So you can see that, so these may be when you administer any drug, so most of the drugs can have a desired response. You can see up to 50 to 75%. And also can cause no reaction, no response or adverse drug reactions about 40%. So among these, proportions, so 3.5 to 6.5% can lead to serious adverse reactions and needs hospitalizations. So that was that NICE guidelines says, and we can see that. So these reactions, happened because of many factors. So difference in that inter-individual responses could be a multifactorial one. So you can see that may be because of the age, so extremes of age in elderly people as well as young, and gut microbiota. So everyone agrees that so pharmacomicrobiomics is an emerging field, and it interferes with the absorptions and kinetics of drug, and also dynamics and also therapy. You can see the lifestyle changes and ethic differences, variability, disease conditions, and gender, and the environmental factors, so can lead to this inter-individual variations. And one more topic, important topic, I'm going to discuss about this genetics. So the gene, so that's involved in driving this variation, inter-individual variation, we call pharmacogene. So that may be at the level of the kinetics or the dynamics, and it can interfere with the therapy as well as it can cause adverse drug reactions. So we'll discuss about this pharmacogenomics in clinical practice. With these introductions, so these are my learning objectives. So we just will discuss about the terminologies related to pharmacogenetics and genomics, and what is the difference between the genetics and genomics, and at what level it can happen to cause these changes in the phenotype, and also the clinical applications and future pharmacogenomics. So you can see just briefing the anatomy of the genome. So you can see that every human cell's bodies contains 37 trillion cells. So each cell possesses DNA. So DNA is a double helix structure, and it has a nucleotide basis. It's paired through the bonds and has a backbone of sugar and the phosphates. So adenine, thymine, cytosine, and guanines. So thanks to human genome projects, it was successfully completed, mapped the human genome. So consists of the 3 billion bases in human body distributed across 23 chromosomes and 20,025 genes in human body. So one gene can have depending upon the size, can have the 3000 nucleotides. And you can see that it's less than 2% that codes the protein. So other proportions of genes said to be a junk proteins. Okay? And just touching upon the central dogma, so everyone is aware about this. So DNA, so get transcripted to mRNA, so mRNA get translated to amino acids. So amino acids, that three amino acids that forms a codon, so that codes for the proteins. So the DNA has several parts here, so promoter, so that enhances the protein synthesis. So we'll have a start site and we'll have a stop site, and we have exons, so that is the regions that codes for the protein. So in between the exons, we'll have the introns, so that will not involve in coding, but it regulates the functions and also the enzyme activity. So that is involved in splicing, and also get the translated protein is only exons. So that again is translated to amino acids, finally we'll have a protein. And here you can see that, so between the two human beings, so 99.9% they are identical, they are similar at a genetic level. So only minimal variations, 0.1% varies, so that only will contributes to the difference in color or hair color, eye color, and also the appearance on this metabolism, etc. So here this difference, that 0.1% may be because of the mutation, or so the mutation if persist, it can lead to persist among the populations, it can lead to polymorphism. So it may at the level of point mutations, we can see that silent, missinus or nonsense mutations. So you can see here, so this is a normal allele, so the DNA level TTC, so it gives to the protein lysine. Okay, so when there is a changes in a mutation happens in any of the codon, so that can produce the same amino acids, we call that silent mutations. So sometimes it may leads to premature stop, we call it stops the codon, and we can have a missense, it can produce a different amino acids. So usually we have that single nucleotide polymorphisms, that is the most frequently happening variant. So SNP we call that. So this is about the, what is gene is a section of DNA, so allele is a variant from the gene, and genotype is a description of the pair of alleles present for a characteristic, and phenotype is the physical expression of the alleles. So with these basics, we know genetics is nothing but a science of hereditary. So refers to as a single gene and its effect, but genomics, the study of entire genome, including the complex interactions among the multiple genes, as well as between the genes and the environment. So genetics, pharmacogenetics refers to monogenetic variants that affects the drug response. So for an example, like a beta receptor, beta blockers respond because of the gene malformism, that is ADRB1. So how it changes in the response about the high blood pressure or the cardiac system. So genomics is nothing but refers to the entire genome. So that determines efficacy and safety. So here multiple genes are involved. So interaction between the multiple genes and also the response that we called as pharmacogenomics. So studying that entire genome, so it facilitates us to individualize the therapy and individualize the dose for the particular patients, and also helps in increasing the efficacy, reducing the adverse effects, and also can improve the adherence. So that we called as personalized medicine. So coming to the goals of pharmacogenomics, so the first aim is minimize the toxicity. So everyone agree that first to do no harm. So aim of the pharmacogenomics is to reduce the adverse effects, maximize the efficacy, and it's helpful in identifying the new targets. So mostly in oncology. So based on this genetic mutations, we'll consider the choose the appropriate drug for the appropriate conditions. And also may predict the patients who respond to the interventions. So these are the goals of the pharmacogenomics. And you can see that the history of pharmacogenetics, it's been evolved. It's evolved from 510 BC to the present genomic era. And it's been started with, so by Pythagoras, they reported that, so consuming flava beans, so resulting in adverse effects, mainly because later they identified that is because of G6PD deficiency. So later on, Gerard, so he has mentioned that specific enzyme defect not only causes inborn error of metabolism, it causes inter-individual variation due to drug response to the drug. So Motulsky, so he has been called as, been named as the father of pharmacogenetics, And also he has done a research in the genetics, and that is inherited some of the diseases like familial hypercholesteremia. He has been found that it's a monogenetic diseases. So another person, important person, he has made a change, great remarkable research in this genomics is Kalau. So he is called that, and he told that he himself is a deficient for, a poor metabolizer for CYP2D6. So he himself, he called that rich man of poor metabolizers. And he has, demonstrated many drugs that is related to that efficacy and the response. So later on, many have come forward, and we know that Human Genome Project first draft comes 2001, and now 2003 it was established. The full genome, human genome was mapped, and still, so we are in the era of going to the personalized medicines. So you can see that genetics variation can happen at the pharmacokinetic level or dynamic level. So variance may be because of SNP, or it can be lead to insertions or deletions of gene or the nucleotide bases or duplications. So apart from that, we have other genetic variants, tandem repeats. So here you can see that nucleotide repeats, a sequence of nucleotide repeats we call as tandem repeats, and sometimes we have a copy number variants. So whole gene sequence that get copied, so duplicated or deleted, so we call it as copy number variants. So this is the nomenclature. So CYP2D6 here, it's a gene. So followed by that, we'll have an, after star, we call it as allele. So after star 2, then we'll have a, A, we call that allele subtype. Okay. So we'll all know, so we're coming to the pharmacokinetics, genetic variation at the pharmacokinetic level. So we all know drug metabolizing enzymes under the phase 1 and phase 2. So there are 57 cytochrome families are there, and subfamilies are there, handful of enzymes only involved in metabolizing most of the drugs. So when there is an allele, so that makes a difference, genetic variant that resulting in the metabolisms may be classified as a poor metabolizer or extensive metabolizers phenotype. And also there may be change in the genotype of that encodes the gene for the glucuronide transferase or other enzymes that involved in the phase 2 metabolism. So the phenotype, metabolizer phenotype based on this pharmacogene variations can be classified into extensive metabolizers or normal metabolizers, normal alleles. So they will carry the 2 alleles for the normal enzyme function. So non-functional means they are poor metabolizers, so they carry 2 non-functional alleles. So in between we'll have an intermediate metabolizer as well as ultra-rapid metabolizers. So they will carry 1 normal and 1 hyperfunction or abnormal hyperactive allele, so that it can result in this abnormal metabolism. So another case presentations just to have a break. So you can see that mother who has been recently delivered a baby, and the baby was normal, and she was prescribed for the post-operative pain. She was prescribed codeine. Early days, nowadays we are not prescribing codeine, and FDA not recommended to prescribe codeine. So this drug was prescribed. So after 10 days postpartum, she has brought the infant. So she has told that the infant has presented with all these symptoms, and it's been going for the respiratory depressions. So here, what could be the cause for this scenario? So mother may be in ultra-rapid metabolizers. So usually codeine will get metabolized to morphine. So codeine is a prodrug. So it gets metabolized to morphine, and morphine that accumulate more, and it can resulting in respiratory depression. So we have to identify such a genotype peoples, and we have to prescribe the drug accordingly. So codeine get metabolized to morphine by CYP2D6, and this morphine is an active compound that produces analgesic effect. So this polymorphism has happened at the level of CYP2D6. You can see that. So normal type is star allele 1. So 2, 3, 4 and all. So it resulting in polymorphism causing either poor metabolizers, or it can have a produces ultra rapid metabolizer role. So it can resulting in toxicity, as we discussed in the earlier scenario. So next example is CYP2C9 polymorphism. So vitamin K. So everyone will agree this. So we'll have this as a multi-genomic variant level. So it can, the phenotype can have either the polymorphism of CYP2C9 or this VKORC1. So this main target is on vitamin K dependent epoxide reductase enzyme. So that is helpful in synthesis of vitamin K dependent clotting factors. So when this gene that codes this enzymes has been malfunction, so it's not able to get inhibit take the target. So it's an example of pharmacodynamic pharmacogenetic variations. So when it take this CYP2C9, so the polymorphism can resulting in, so when it is a poor metabolizers, it cannot be metabolized, the level will be increase in bleeding tendencies, so that it should titrate, the dose should be titrated. So FDA recommends, so based on the genotype, so we have to prescribe the dose for the warfarin, using the warfarin. So we could see the different populations in the frequency of the polymorphism is different, and we have to choose the drug accordingly. So another drug example is clopidogrel. So that is also metabolized by CYP2C19. And you can see that it's a prodrug, it converted to active metabolites to have an antiplatelet effect. So if it is a poor metabolizers, so you can see that, so the level of the clopidogrel may be increased, and it can have, more, concentrations may be more, and it can resulting in the efficacy, but it is not metabolized properly. So it can land up in adverse effects, therapeutic inefficiency. And also we should think about the interactions with the omeprazole, because omeprazole is a CYP2C19 inhibitor. So you could see here, this is normal allele, it's CYP2C19 and *1. So 17 is an increased expression. So ultra rapid metabolizer, you can see that phenotype will carry this 2 gene increased expression. And you can see that in the intermediate poor, so there will be combination of this normal allele as well as the increased expression allele. So you can see the different populations will carry the different level of proportions of this phenotype. And so we have to check for this pharmacogenetic testing, and we have to titrate the dose and change the another drug for the therapy. So another enzyme is CYP enzyme is CYP3A4, and you can see that here tacrolimus has been metabolized by this. So there may be, you can see that concentrations of the CYP function, concentration is increased when there is an hypofunction. So you can see there in the graph, B graph, so CYP3A4 hypofunctions because of genetic malformism happen. So concentration may increase, and also it also involved in the reduction of the renal clearance. So it can resulting in toxic effects. So it can lead to adverse effects. So TMT, that is thiopurine 6-methyl transferase, polymorphism can resulting in, so this is the enzyme that plays a key role in conversion of 6-mercaptopurine to this inactive metabolites. So if it has been involved genetic variations, you can see that increase in the level of 6-mercaptopurine and increase in more bone marrow toxicity, neutropenia and all, it can happen. So these are all the drugs that will have a few examples of drug gene pairs. So azothiopurine and mercaptopurines, because of the genetic variants at the level of TPMT and also NUDT15, so it can classify the phenotype into poor metabolizers or intermittent metabolizers, and you will have that FDA recommendations to titrate the dose accordingly based on the variations in the genotype. And we'll have another organization called Clinical Pharmacogenetic Implementation Consortiums. So that explains more, and also it gives many drugs and the genetic variant phenotypes, how to go about with the drug and the dose. So we have another examples of UGT polymorphism here. So irinotecan is a drug that is used for colon carcinoma and solid tumors. So it converted to SN38. So SN38 is a toxic metabolite. So here what will happen, so that has to be converted to inactive metabolite. So if there is a polymorphism at the level of UGT1A1, so what happens, this conversion will not happen, so increase in the level of SN38, it resulting in a diarrhea and neutropenia. And also N-acetyl transferase, if everyone will agree about this, is with the antitubercular drug isoniazid. So here, so when there is a polymorphisms with this NAT2, so it can result in the become a slow acetylatase. We will usually classify them into slow and fast acetylatase. This will lead to peripheral neuropathy as a more common adverse effects. So tamoxifen, another drug. so that undergoes by CYP2D6, and we'll have sulfonyl transferase, that is a enzyme. It converts this into active compound, that is endoxifen. So endoxifen will have an anti-estrogenic activity. So when this conversion is not happens, it can resulting in therapeutic failure. So another example is we'll have this acetaminophen metabolism, paracetamol metabolism. So not only due to overdose we have seen, but there is a polymorphism at the level of GSTM, that is glutathione transferase enzymes, so that it cannot get cleared into the intoxic metabolites. So we can see that NAPQ1 get accumulated, it can resulting in hepatotoxicity. So these are the other drugs that gives an example for having a potential impact on the efficacy. So we have ifacaftor, that is acts on that the CFTR, it's used for cystic fibrosis. So when there is a mutation in the CFTR gene, so that it can resulting in therapeutic failure. So we have other examples, codeine, tramadol, tamoxifen. So their concentrations will be increased in the plasma because of the poor metabolizers. So we have to change the drug for the that condition. So another example with the transporters. So here with the digoxins, so get, P-glycoprotein is a main thing. So here the protein encodes its ABCB1. So when there is a polymorphism happens with this, so it can resulting in transportations or systemic absorption of, into the tissues. So that the level of digoxin will be more in the serum and causing digoxin toxicity. So statin, everyone will know that. So SLCO1 B1 allele, genetic variant. The people who carry this variant, so it can resulting in more rhabdomyolysis and some causes myopathy because of this polymorphism. So these are all other drugs that under the statin also capable of increasing in concentration because of this genetic variation. So another article, we have seen that voriconazole is an antifungal drug, so that oral absorption also get affected by the genetic polymorphism at the level of SLCO2BB1. So pharmacodynamic, pharmacogenetic, based on this, we could see that beta receptor blockers. So when there is a subject having this glycine 328, we can have a increased sensitivity. And with the patients, we have serine 49 glycine protein, so it can show that increased sensitivity to beta blockers. So there may be a changes in the response based on this amino acid transpositions at the level of. So another example I want to give about the off target, so beyond the target. So we know that aminoglycosides that target 16S RNA, so we inhibit the bacterial protein synthesis. So here what will happen when this polymorphism has happened at the 16 RNA. So this that human cell in the auditory systems that mimics that of bacterial cell, so that it targets the cochlea and causes ototoxicity. So that is an example for the pharmacodynamic part. And you can see that other drugs like antidepressants, so the receptor, serotonin receptor polymorphism can alter the receptor function and also produces variable responses. So we have beta blockers, ACE inhibitors, statins, antiarrhythmic, asthma drugs. These are the few examples. They can have a difference in the pharmacodynamic or the response based on the genetic variation. So we have seen about the single gene that produces the polymorphism produces a difference in the response or difference in the concentration, serum concentration. So some of the phenotype can possesses the two genes. So for an example, with the warfarin, so you could see about that CYP2C19 and also VKORC1 polymorphism can happen. Maybe in gene can play a role, and also phenytoins CYP2C19 HLA B1501 changes. So when you see that, so CYP2C19's poor metabolizers can lead to phenytoin toxicity. HLA-B1 can cause Stephen-Johnson syndrome. So some of the people may possess these two gene polymorphism, so that for those patients we should not prescribe this drug. So you can see the different genes play a role in different actions. You can see that CYP2C19. So there we have to adjust the dose based on the INR. So we have to reduce the dose, but for CYP452 polymorphism, we have to increase the dose because it converts the inactive metabolite so that it plays a main role in the vitamin K metabolism. So here we have a guidelines for the prescription of dose to the different phenotype of warfarin patients when you prescribe warfarin. So G6PD deficiency, everyone are aware of that, anti-malarial drugs. So they have an high probability going for this G6, hemolytic anemia. So when you prescribe for the patients with G6PD deficiency. So immunogenic pharmacogenics we have that HLA ABC, and there is a polymorphism at the level of AB, so it can result in toxicity. Few drugs are example here. So phenytoin toxicity with the HLA B1502, abacavir with the HLA B5702. So all these can lead to serious reactions like Stephen-Johnson syndrome. So these are all few examples. Okay, so we have discussed about this polymorphism at the level of HLA-B. So apart from, this pharmacogenomics helping in titrating the dose or changing the drug therapy accordingly, so it's helpful in developing a new drug. So identifying these genes, so that may play a role in the pathogenesis of a tumor or anything, so we can identify and we can treat accordingly. We can find a new target. So one example is PCSK9, it's an hypolipidemic drugs, and we have recently approved by the FDA suzetrigine in migraine, and also many other oncology anti-cancer drugs, trastuzumab and imitimib, so that targets the genes. So summarizing the drugs that probable of causing polymorphisms in the CNS, so you can see that all the most of the anti-epileptic drugs, antidepressant drugs, so you could see that HLA-B 1502 probable of causing Stephen-Johnson syndrome, and also clozapine can induce agranulocytosis with a phenotype of HLA-DQB1 variant. So cardiovascular, so many drugs are there. So warfarin we have discussed, clopidogrel, aspirin, beta blockers, statins, digoxins. So can very careful while prescribing the drug to the patients with the different expressions of gene. So cancer drugs, cabicitabine converted to inactive metabolite, 5-fluorouracil to inactive metabolite by DYPD enzyme. So when it get polymorphism, so it will not get converted to inactive metabolite. So we'll have this 5-fluorouracil is potential to cause more adverse effects, and mainly the bone marrow depression, etc. So sulfonylureas, so anti-diabetic drug metformins, so we've been using for the patients liberally. So we have to think about that genetic polymorphisms. Accordingly, we have to treat the patients. So having discussed about the genetic variations at the level of kinetics, dynamics, and helping in the new drug development, so it can be useful in many ways. So reducing the adverse effects, maximizing the efficacy, and we can predict the people who respond, not responders can be identified, can avoid the drug interactions with this pharmacogenomics. So in clinical practice, we have point of care testing, and we have to follow this CPIC guidelines, that is clinical pharmacogenetic implementation guidelines are there. So that will have all the data about the genetic variants, and also they'll have drug gene pairs, and also the recommendations for the physicians regarding the dose, and also guidelines also been captured here, what the FDA says, what that Health Canada says, everything is there in the CPIC guidelines. So we want to go about the pharmacogenetic screening before prescriptions. We can look into the database and we can prescribe accordingly. So this is a point of care. So we have a panel of tests. So it can be done. So to detect the genes, whether it undergoes mutations and all. And you can see that this is an AmpliChip. This is the first, software approved for this pharmacogenetic test, and it's taken from GG book. So we have actionable pharmacogenes. So these are all listed here, and so the database where we can go about this pharmacogenetic testing and identify the variant genes and the recommendations about the doses or the therapies, we can look into that CPIC and also PharmGK, that is genomics knowledge-based database. So that works a lot. That has been funded by the NIH, and that has a data of genotype and phenotype data and about the drug response. And form where we have that alleles, it's keep on updating the, whenever new or rare alleles have been identified, it's updated in the database. So you can see that US FDA website, so they have not only the drug under the drug approved list and other informations, it also has the table of pharmacogenetic association. And you can see that pharmacogenetic association, the therapeutic level or the data to be included in the label. So all this been mentioned in the US FDA database. And this is consortium I told that about that CPEC, and it has the drug gene pass and about the all guidelines how to prescribe when there is a different type of phenotype have been identified, and what are the guidelines that says that, so whether it is an actionable pharmacogene or it is not recommended or not recommended, everything has been provided in this database. So apart from that, this CPIC, so that provides a level of certainty. So whether it can be recommended, the strong. So if it is any RCT has proven this gene variation that could cause this adverse effects or the therapeutic effects, you can see that that's stronger, moderately or high. So everything they classified. Different guidelines. We have the CIP and also PharmGKB and also Dutch pharmacogenetic working group. So we could see that's another genome project. So that has been started by the DBT. So the Genome India project has been started. So we have Map My Gene, and also this has also been useful in detecting the genetic variations, and also AI in pharmacogenetics is coming up. And this will capture all the data and can integrate the data of genetic variants into the electronic health record, so that will be useful to choose the drug for the patients. So this is the future advances in the pharmacogenomics. So it's been AI assisted. So we'll have the digital pharmacogenomic passports everyone will have, and also integration into primary care, healthcare, and as a preventive and CRISPR guided therapeutic targeting. So we have the challenges still been developing and developed. So we'll have the challenges because of the cost effectiveness and turnaround time for genetic testings will be around 2 to 4 weeks. So it gets difficult to prescribe for the patients appropriately, and education is needed for the clinicians, and the complexity of the laboratory and availability of the infrastructure facilities. So, and also the privacy of the data of the patients, everything plays a role. So these are all challenges. So all the stakeholders involved in the regulatory or in the diagnostic aspects or in the clinical decision making should come up, it should change this one-size-fits-all approach to the personalized medicine. And this personalized medicines to be tailored based on the pharmacogenetic variants, and so that it should produces the maximum efficacious and less adverse effect. These are the methods of pharmacogenetic testing. And also by doing this test, by identifying this, we can classify them. So not giving the single dose for all the peoples, we can change them according to the response, like different doses. And so this is what the future healthcare expected. So 4 Ps with predictive, preventive, personalized, and participatory. This is a transforming healthcare. So summarizing this, so in this is a cornerstone, pharmacogenomics is a cornerstone of precision medicine and modern clinical practice. So I like to conclude tagging the, tagline of this MPSCON. So smart drugs, so smart data and smart decisions. So that will help you in choosing the right drug to the right patients. And thank you for the patient listening.
Thank you, ma'am. It was a very nice presentation with elaborately presented. I hope all the delegates, especially the postgraduate, will have a it will be very helpful for them. Thanks, ma'am. And precision medicine is an upcoming topic. It will be, in the future, we will have only targeted therapies. Nice, ma'am, for the nice talk, especially the case scenarios. You have started with the case scenarios.
Thank you.
Nice,
Thank you.
Thank you. Okay, anybody wants to say something?
Yes, sir. Yes, sir. Actually, presently the FDA, so whatever the guidelines, when you do clinical trials, they want to do parallelly about the many genetic variants and their response to the drug also. So they emphasize that pharmacogenomic data to be incorporated and to be submitted to the FDA while submitting for an approval. So they insist they want to integrate into the clinical trials, and the data is very important to make a decisions for the effectiveness of the drug.
My next question is, only dermatology department is implementing on pharmacogenomics. Why not other departments?
Yeah, it must be.
Means it is only precise only for dermatology department or not other. Even oncology people are not implementing pharmacogenomics.
Yeah. So actually, this is emerging in the oncology department and psychiatry, and I think. But dermatology, I could say that because they could see the seriousness of the adverse effects of the drug. The patients who possess this phenotype, change in the, the genetic variant.
The next part is pharmacoeconomics. Our drug discovery and pharmacoeconomics will not fit into the cost of genomics. Each genomic test will cost us almost 30K.
Yes, sir. It has an advantage as well as it has an limitations regarding the cost factor. So, because when we prescribe the drug, that's not suits to the patient or the person, so that also it's a burden to the financially burden to the patients.
And
not been
reading
recovered.
The genome report is almost 400 pages. When I read that report, I have a typo error or an error writing that report, which will lead to again malformation of all the treatments.
Yeah, it has to be changed, I think, sir.
Actually, in this regard, I want to say something. Regarding the cost effectiveness of the gene testing, actually researchers are going on. How can they implement that in a normal OPD? Especially in a country like India and a third world country, how can they implement that genetic testing in OPD? So researchers has been going on just to minimize the cost of the genetic testing.
So usually you take blood sample, we are taking tissue sample also and trying to extract genes.
Saliva, sir, saliva.
Saliva. We take for example, hysterectomy, uterus tissue and try to see the morphism in those type of tissues also.
So again, invasive, I think, so how it can be acceptable.
Yeah.
So next. Time is short. Sorry for interruption. We are running late. Ma'am will be available in the hall, so you can ask the questions, any other questions. We are ending the session. Thank you.
Thank you. Thank you.
Thank you for the insightful presentation, ma'am. I would now like to request the chairpersons to felicitate our distinguished invited guest speaker, Dr. Kavita R.